Okay, I'm going to start. So I'm doing approach to psychiatric conditions in the emergency department. So just before we start, what I want to just make clear here is that it's involving patients presenting with psychiatric symptoms, not necessarily every patient presenting with psychiatric symptoms is necessarily a psychiatric patient. There's a whole host of other things that we need to exclude, which is very much our purpose in the emergency department. All right. From beginning. Okay, so what constitutes a psychiatric emergency? So these are patients with disturbances of thought, mood, or psychomotor activity in which they pose a threat to themselves or others. These conditions require immediate intervention to firstly safeguard the patient, secondly to safeguard the others in the environment, and then finally to relieve anxiety of the family members, who are often the people who bring the patients to the emergency departments with concerns. So due to lack of other facilities, the ED has become the primary acute setting where patients seek mental health care. So I just want to start with 3 cases. So firstly, we have a 72-year-old male. He's brought to the ED by his family with a history of progressively worsening confusion for the past 2 days. He's hypertensive and diabetic. He's on Prexim and Protophane, but has poor adherence to his medication. His family says he's been talking to himself, refusing to bath, soiling himself, and in general, he's been combative. Second case, a female patient. She appears to be in her mid-30s. She's brought in by the police. She was found wandering up and down the road. She's half-dressed, shouting, swearing at passers-by. Her speech doesn't make sense and she appears unkempt. She doesn't respond appropriately when she's asked questions, and she cannot give any contact information for friends or family members. And then finally, the third case, a woman brings her 2 children, 6 years old and 10 years old. She reports that she left the children at home with her neighbor while she went shopping. When she came home, she found the children to be alone in the house. The older child was hyperactive, responding inappropriately, talking and laughing to himself. And the younger child was lying on the floor and difficult to rouse. So the reason I put these 3 cases in is just to show again that all 3 of these patients are presenting with psychiatric symptoms and with abnormal behavior, but thinking of those 3 different patients or 4 different patients, we'd have very different differential diagnoses, and we'd be looking for different things in a 72-year-old male presenting with abnormal behavior versus the 2 children. And we'll come back to that again later. So just in terms of our general approach, one of the primary functions for us in the ED when dealing with these patients with abnormal behavior is going to be to determine their disposition. Are they actually a psychiatric patient, or is there something else going on and they're presenting with psychiatric symptoms secondary to a medical cause or substances or so on. And this is important because a lot of things that can cause patients to behave abnormally can be life-threatening and are treatable. So it's really important that we identify those. So just the general approach, we'll start with the history. So we'll do current symptoms, precipitating events, past psychiatric and substance history, a full medical history, and a family history. And extremely important here is collateral, because we often won't get a complete story or an accurate picture from the patient themselves. I know with the psychiatric history, there's a whole lot of other things, school history and social circumstances and all that. So it's not as relevant to us here. Then examination, we'll do a full physical examination. And just important to keep in the back of our minds when we are examining these patients is, do their signs fit in with any possible toxidromes that, again, can be life-threatening and are treatable. And then the investigations that we'll do in the emergency department. So we have our point of care tests. So we do a finger prick glucose, a urine dipstick and drug screen, urine pregnancy tests, and then a blood gas. In our general lab tests, we'll do an FBC, a UNE and a CRP, an LFT, TSH, and an RPR. And we can do a lumbar puncture, but this is definitely not for every patient. This is only if we have reason to believe on our history and examination that there might be an intracranial cause. Then toxicology, we can do an ethanol level and serum drug levels. And then on imaging, we can do an ECG, chest X-ray, And we can do a CT brain, but again, this would only be if we have reason to believe there might be a space-occupying lesion or some other intracranial cause. And then, of course, we can add on to these tests depending on what we find on our physical exam, and if we have reason to believe, there might be something else going on that we can test for. Okay, so if we move on to our common ED presentations, so we're going to go through this whole list, and I'm not going to mention them one by one right now. Okay, so we're going to start with delirium. So important again to remember that delirium is actually not a psychiatric diagnosis. A delirious patient is a patient presenting with psychiatric symptoms secondary to an underlying cause. So delirium is a disturbance in consciousness with inattention. It's accompanied by a change in cognition or perceptual disturbance that develops acutely and fluctuates. Right, so there's quite a few things there, but what's very important here is that it's an acute onset and it fluctuates. The patients can present with hyperactive symptoms or hypoactive symptoms, or a mixture between the two, and again, they fluctuate. And there's a prevalence of 80% in the critically ill of delirium. So why is this significant? There's a more than 3 times increased mortality at 6 months in adult ICU patients. Delirium prolongs ICU admissions and hospital stays, and then again, those also predisposed to things like nosocomial sepsis and bed sores and all those. And then there's a measurable cognitive deficit in 50% of patients at 6 months. So if we're looking at our assessment of delirium, so there are certain risk factors, so age, pre-existing dementia, history of hypertension or alcoholism, if there's a high severity of illness at admission, and sedative use. And then our approach would be, again, as usual, focus history, examination, and investigations, assess for any of these predisposing or precipitating factors. And then importantly here, we can use a delirium monitoring tool. So the one that I've put here is the CAM ICU. It's a confusion assessment method. So it's actually recommended to use a delirium monitoring tool. It's much easier to identify delirium because it is often something that you forget or might not think of. And it's much easier to assess and confirm whether they have delirium or not by using an actual tool rather than just trying to decide from looking at the patient if they're inattentive or disorganized. So with this CAM ICU tool, we'll look at is there an acute mental status change currently or in the past 24 hours, and has it been fluctuating? If yes, we'll assess for inattention. Then we'll look at their current level of consciousness, but remember they fluctuate. So their current level of consciousness might be normal. That's why we looked for what happened in the past 24 hours. The current level of consciousness, we'll use that Richmond sedation scale. And then the last thing we'll assess for is disorganized thinking. And then we can say with some confidence whether the patient is delirious or not. Then to manage delirium, so the most important thing that we can say here is to seek and treat the cause. Because again, delirium is not a diagnosis in itself, it's a symptom of an underlying illness. So there's an acronym here called WIP2 that lists the life-threatening causes of delirium. So that would be Wernicke's encephalopathy, withdrawal, especially from alcohol, hypertensive encephalopathy, hypoglycemia, infection, intracranial disease, poisons, and porphyria. So these are all things that we need to actively search for and treat. Then in terms of medication and things that we can give, so there's no actual approved drug protocol for the treatment of delirium, because again, it depends on the cause, but there are things that we can give in general. So first we'd give thiamine. This would be if we suspect alcohol consumption or poor nutrition. We can give atypical antipsychotics. They may reduce the duration of the delirium. We can decrease sedatives, or if we do need to give sedatives, then we can try and give sedatives that are less likely to cause delirium, like dexmedetomidine, and then avoid precipitating drugs. Then in terms of non-pharmacological management, patients must be frequently orientated. We must try and push for early immobilization and physiotherapy, remove indwelling catheters, have a good day-night routine and sleep hygiene, control noise at night, and then finally correct vision and hearing impairment. Okay, then we go on to substance use disorders, which is really a big topic on its own. But so we'll just look at the broad categories of substance use disorders. So first we'll look at the CNS depressants. So the important ones for us are alcohol, opioids, and mandrax. The important opioids are heroin and Niape, which is heroin and it's usually mixed with something, and in our setting it's often mixed with ARVs. So patients intoxicated with these CNS depressants, initially they can be euphoric and have increased energy. And then later they become drowsy, have impaired coordination, slurred speech, psychomotor retardation. And with a potentially lethal overdose, they can have respiratory depression, hypoglycemia, seizures, and coma. Then if we look at withdrawal, so I'm going to go into detail with alcohol withdrawal, but just in general. So we'll have GI distress, anxiety, irritability, autonomic instability, and tremors. So in treating this, as always, we start with ABC. Intubation and ventilation might be necessary for a depressed level of consciousness, or they can have prolonged seizure activity. And then in terms of specific treatments, so for opioids, it would be naloxone, and for alcohol and mandrax, we treat it with benzodiazepines. Just to note with the naloxone, this is often more useful for diagnosing opioid intoxication than for treating it, unless we have them on an infusion. But if the patient is intubated and ventilated with an opioid overdose, then we need to keep them intubated until they are fully awake without any naloxone at all, because the naloxone will wear off faster than the opioids. Then we have CNS stimulants. So first we have methamphetamine. So this is known locally as TIC, very common in the Western Cape. Then cocaine and cat. So these patients will also present with euphoria, increased energy, pressure of speech. They become anxious and paranoid, and they can be aggressive. They have autonomic arousal, and they can present with dysrhythmias and seizures. Then withdrawal, so they become agitated, depressed, anorexia, insomnia. Then they have this honeymoon phase where they temporarily feel better. And then following that, they hit what they call the wall. So this is actually a major hurdle to recovery for these patients, because by the time they discharge from inpatient rehabilitation programs, they have not yet hit the wall. So that only happens once they're already discharged, and then they're very susceptible to relapse. Medical detoxification is not required. Sorry for my dogs in the background. Medical detoxification is not required generally for CNS stimulants. Then we look at psychedelics. So this would be cannabis, ecstasy, and LSD. Again, the presentation is similar. They're euphoric, motor incoordination, impaired judgment. They can have perceptual disturbances. They'll be tachycardic. They can have postural hypotension with cannabis, or hypertension with ecstasy and LSD. And then severe intoxication, again, an unsteady gait, slurred speech, sedation, and so on. So withdrawal, cannabis is similar to alcohol and opioid withdrawal, but it's less severe. You can use benzodiazepines, but it's not generally necessary. And then with ecstasy and LSD, no medical detoxification is required either. So then I just want to focus on alcohol withdrawal here, because it is probably the most common one that we see, but it's also difficult to recognize. And it has a mortality rate of 20% in severe cases if it's left untreated. So this usually manifests within 48 hours from the last alcohol consumption. It's divided into 4 stages, but there is quite a lot of overlap between the stages. So they'll start out with anxiety, restlessness, inattention, insomnia, and then these tremors that they call the shakes. And then they become irritable and hypervigilant. They can start hallucinating. Then this progresses to seizures. And then finally, the most severe and what's actually life-threatening about alcohol withdrawal is if they develop this delirium tremens. So this is a global confusional state in which the patients become hyperadrenergic. So they are diaphoretic, they shaking, they're hypertensive, tachycardic, and then again, having hallucination and seizures. So in terms of management of alcohol withdrawal, so we need to assess them according to this CIWA A scale. So again, this is the same as what I said previously with the delirium, it's good to have an actual tool that we can use to assess the severity and guide our treatment of alcohol withdrawal. So for this particular scale, there's 10 different sections that you'll give the patient a score for, from, for all the symptoms that they're having: nausea and vomiting, agitation, hallucinations, etc. So each one of those 10 things gets a score. The maximum score is 67. And then we can assess the severity of the withdrawal. So if they score less than 10, it's mild. Between 10 and 20 is moderate, and more than 20 is severe withdrawal. And then in terms of treating them, again, we start with A, B, C, D, E's. Patients might need to be intubated and ventilated if they have a decreased level of consciousness or if they have prolonged seizure activity. Then we give diazepam, or any benzo, but we like to give diazepam because it's longer acting. So we'll give the benzos to achieve a light sedation to abate the withdrawal symptoms. Then we give thiamine. This is now to prevent Wernicke's encephalopathy. Then correct other abnormalities, so hypoglycemia, hypomagnesemia, if they have those. Supportive care, and then if they're hallucinating, we can give haloperidol. But it's just important to keep in the back of your mind that haloperidol can decrease the seizure threshold. So I don't think this would prevent you from giving it, but just important to know that. All right, then medical mimics of psychiatric illnesses. So I'm not going to go through this entire list, but the point here is just to show that there really are a lot of medical conditions that can mimic psychiatric illness, and this list is not even exhaustive. So we really need to be active about looking for any underlying conditions before we just write the patient off and say, oh no, but you're a psychiatric patient, refer to psych. We need to have a high index of suspicion for other medical conditions going on underneath. Okay, then we move on to the aggressive patient. So what is aggression? This is behavior which may result in harm to oneself, others, or the environment. It's more common in males and those with a history of aggressive behavior. But important to note that not every patient presenting with aggressive behavior has a mental illness. And in fact, most patients that become aggressive are not necessarily mentally ill. So if we look at the causes, you can have psychiatric conditions or cognitive disorders that cause aggression. It can be organic causes, so general medical conditions, or substance intoxication or withdrawal. And then actually most commonly is environmental factors. So these would be situational stresses, frustration at long waiting queues, direct provocation from other patients or staff members, and so on. And a lot of aggression in patients is actually provoked by the patient perceiving their frustration as being ignored. So if we can identify this and act on it early, then we can prevent an agitated patient from progressing into an aggressive patient. So managing this, we need to first and foremost try and prevent environmental situations that might predispose to aggression, avoid long waiting periods, limit environmental stresses, and then have clear protocols for dealing with aggressive patients in the department. Then de-escalation techniques. So the point of this is to decrease the level of arousal so that discussion with the patient becomes possible. And this is useful in mild aggression, but it's not appropriate in severe aggression or substance use where the patient can't really be reasoned with. Then if this is not working, we can move on to mechanical restraint, but this is really a last resort as far as possible. You really don't want to reach a point where you're having to mechanically restrain and sedate someone just because they got upset at waiting times and so on. So the way in which we restrain someone, we try and bring them down head first. There's one person who talks to the patient and to the other people involved in the restraint. Then there's one person for each limb and one person for the head and to maintain the airway. It's important not to keep the patient head down for longer than 3 minutes, and important not to put any pressure on the chest. Then we can use this opportunity to give medication if necessary to sedate the patient, and then we can put the patient in seclusion, but it's important to observe them every 30 minutes. All right, then psychotic disorders. Okay, so psychosis. This is a disorder of thought, form, or content. It's often associated with perceptual disturbances. So these would be hallucinations, delusions, which are fixed false beliefs in spite of overwhelming evidence to the contrary, disorganized behavior and thinking, and cognitive impairment. So there are multiple causes of psychosis. In terms of psychiatric illnesses, we can have schizophrenia, schizoaffective disorder, brief psychotic disorder, peripartum psychosis, and then we can again, of course, have organic causes. So I just want to mention here again that for us in the ED, it's not really important to decide what functional cause the patient has. We don't have enough time with the patient, and we're not going to be able to know if the patient is schizophrenic or if they're just having a brief psychotic disorder, because we just don't have the time and capacity to make those diagnoses. So our function is to decide, is it a psychiatric illness, and rule out the organic causes. So in terms of management here, it's actually quite similar to what I put up for the aggressive patient. The primary concern here is patient and ED staff safety, because these patients can be aggressive and unpredictable. So we can try de-escalation techniques, but less effective than with an aggressive patient who's not psychotic. And then we're more likely to use chemical sedation here. As far as possible, we want to use a single agent, and the goal is rousable sleep. It's not to have a completely unconscious patient. It's important to monitor for respiratory depression here. And then the drugs that we commonly use for sedation will be, we'd like to use short-acting benzos. We can use haloperidol, and then just not to forget, it's not on the slide, but ketamine we can always use. It's very safe, and we can give it through virtually any route of administration. And then finally, we can physically restrain patients. And what's important to note here is that actually when we physically restrain patients, we're supposed to be filling in Mental Health Care Act Form 48 whenever a patient is physically restrained, which I don't know if I've ever seen that form, but that's what we're supposed to be doing. And it's important to frequently examine patients when they're restrained, because we can cause injuries to the wrists and across the chest, and that depending on how we restrained them. Then we move on to mood disorders. So mood disorders are defined by the presence of mood episodes. These episodes can be depressive, manic, mixed, or hypomanic. So I've just listed on the right here the symptoms that are associated with a depressive episode and a manic episode. So a depressive episode is characterized by depressed mood, increased or decreased sleep, decreased interest in activities, feelings of guilt, decreased energy and concentration, increased or decreased appetite, psychomotor agitation or retardation, and suicidal ideation. And then a manic episode is characterized by grandiosity, a decreased need for sleep, pressured speech, increased participation in pleasurable activities, but those that usually have painful consequences, increased activity, flight of ideas, and distractible. And then you get different types of mood disorders. So we can have depressive disorders, which would be major depressive disorder or dysthymia. We have bipolar disorders, and then again, secondary to organic causes. So I'll just put a slide on postpartum depression in here, but just because of the setting that we are specifically in. So postpartum depression is essentially a major depressive episode with onset within 4 weeks of delivery. So the duration is usually 2 to 6 months, but you can have residual symptoms up to 1 year. Risk factors are history of a mood disorder, whether it was peripartum or otherwise, and then psychosocial stresses. So these would be things like unemployment, marital conflict, and unwanted pregnancy, and so on. Then in severe cases, the mother can have extreme disinterest in the baby and can have suicidal and infanticidal ideation. And actually a high number of infanticides are related to command hallucinations to the mother when she has psychotic features to kill the baby. So this needs to be treated with psychotherapy and SSRIs. We probably will not be the people initiating the SSRIs in the ED. And it's important to note that this can have a negative impact on child development. So these children can have behavioral and attachment problems as they get older. And then just to differentiate this from postpartum blues. So postpartum blues are seen as sort of a normal emotional response in the postnatal period. So it's a transient period of depressed mood and anxiety and concern over one's own health and the baby. Normally only lasts up to 10 days, and it does not need to be treated with any medication. And then the other emergency that we may have to deal with related to mood disorders is a suicidal patient. So this is really an epidemic in itself. in South Africa, there are 23 suicides recorded daily and 460 attempts daily. The most common methods are hanging and poisoning. And 10 to 15% of patients who have previously attempted suicide will ultimately die by suicide. So there's a nice acronym here for the risk factors for suicide. It's called SAD persons. So it's more common in males. So females have higher suicidal ideation, but males have a higher suicide mortality. Then age, either adolescents or elderly, depression, a previous suicide attempt, even if it's a distant previous attempt, excessive alcohol or substance use, rational thinking loss, lack of social supports, an organized plan, no spouse, and then sickness. And this would specifically be chronic illnesses that cause chronic pain, and illnesses that affect activities of daily living. So when we're risk assessing a suicidal patient, I've put two different risk assessments here. So the one on the left is a brief risk assessment, which is what we would usually do in the ED. On the right is a comprehensive risk assessment that would more likely be done by psychology or psychiatry. So this is also just a nice tool. So it's actual questions that we can be given to assess the suicidality or the suicidal ideation of the patient, instead of sort of just trying to come up with it by yourself from talking to the patient. So there's 7 questions here that you can ask the patient, and if they score 1 or more, then they need to be assessed for a full suicide risk and be referred to a mental health care. So in terms of management, a patient who has come in with a suicide attempt, those automatically need to be or receive a comprehensive risk assessment and be referred to psychology or psychiatry. If you're looking at the top line there, so that's a patient who comes in with suicidal ideation, but has not actually had an attempt. And this actually does happen. Patients do come to the ED and say, I came because I've been thinking of killing myself. It's not always following an attempt. So these patients need to, we need to assess their capacity. We can then use that brief risk assessment and decide whether or not they need to be referred to psychiatry or not. It is possible to discharge these patients without being referred to psychiatry if they score low, but then we need to have a good follow-up plan, and we usually make then a suicide prevention contract with those patients. And on the right is a table that just has some of those safety plan components. And suicide is actually a difficult thing because, I found that sort of depending on which psychiatrist you speak to, you'll get a different answer. So if the patient is a high suicide risk, then of course they are a risk to themselves, but they're not necessarily incapacitated. They, can make decisions. And to say that all these terrible things are happening in my life and I don't want to live anymore, it's not necessarily irrational. So it's difficult to really say whether these patients can be admitted involuntarily or not. But from our side, we'd refer those patients to psychiatry, and always remember that we do have the Mental Health Care Act Form 1 that we can do an emergency 24-hour admission if necessary. Then anxiety disorders. I'm going to just speed up a bit because I only have 10 minutes left. All right, so they are very prevalent. It surpasses any other mental health condition. Half of these patients never receive appropriate treatment. And interestingly, 42% of patients initially thought to have anxiety disorders are later found to have organic disease. So again, we have a number of different functional causes of anxiety disorders. And then important organic ones to look for here are cardiac, so things like MIs, dysrhythmias. Under endocrine, we must look for hypothyroidism. For respiratory, things like PEs and asthma. And then again, substance intoxication or withdrawal, because these patients can become very anxious and agitated. And then what will often present to the emergency department is a patient with a panic attack. So it's important to note here that a panic attack is a diagnosis of exclusion after we've excluded those important cardiac, respiratory, etc. Conditions. So this is an abrupt fear or discomfort. It reaches its peak within minutes and has associated physical and cognitive symptoms. So it can occur with an anxiety disorder or not necessarily with an underlying anxiety disorder. So these patients present with chest pain, palpitations, sweating, shortness of breath, and they have this irrational fear of dying. So in terms of management, we have non-pharmacological interventions. So put the patient in a calm and quiet environment, educate them, talk to them, go through breathing techniques. In terms of pharmacological management, we'll give them short-acting benzos. They can be treated with SSRIs or SNRIs, but again, we usually won't be the people initiating that. That will be done by psychiatry. And importantly, we don't want to give extended benzotherapy on discharge, because remember that it is a drug of abuse. So normally, when the patient is discharged, we can give benzos for about 10 days just to bridge that gap while we're waiting for the SSRIs to take effect, but not long-term therapy. Then most of these patients can be discharged home, but it's important to have a good follow-up plan and to educate them well. Otherwise, they have a high risk of returning with the same thing. Then personality disorders. So personality disorder is not really, an emergency, but we do often see them. So personality disorder is a pervasive, inflexible pattern of inner experience and behavior that differs markedly from the individual's culture. So you can have dominant traits of a specific personality type, but it does not necessarily mean that you have a disorder, or you can show traits from multiple clusters. So we have cluster A. So these are patients who are normally seen as sort of odd and eccentric and withdrawn. Then we have cluster B. So these are patients that are seen as sorry, I'm losing my train of thought. That are seen as like sort of dramatic, and we have a lot of sort of counter-transference to them. And then the last is cluster C is sad. So these are avoidant, dependent, obsessive, compulsive. They're sort of withdrawn from society. So I just want to mention borderline personality disorder because that's what we'll see most commonly. And we'll actually often see this in the parents of the children that we're seeing. So they're very frequent users of the ED. It's often provoked by interpersonal conflict, and borderline personality disorder patients actually have a 10% suicide rate. And they're very difficult to manage because, as I said, there's a lot of counter-transference to these patients. They're seen as dramatic and irritating and just looking for attention. So what's difficult here is that comorbidities can mask a clinical picture. So that patient might come in having, a PE, and our response is sort of, oh, they're just being dramatic, they're looking for attention, they're being irritating, and so on. So we need to be aware of our own feelings of counter-transference and make sure that we are actually managing the patient correctly. It can be difficult to establish rapport with these patients, and there is healthcare worker aversion to wanting to see these patients. Then just a quick word on child psychiatry, just because of our setting. So, I mean, this again is a huge topic just on itself, and there's a lot of conditions that children can present with that are not seen in adults necessarily. So things like conduct disorder and developmental disorders and that. So it's just important to keep in mind that the common symptoms that children can present to the ED with that might point to an underlying psychiatric condition. So a lot of children with anxiety come with these non-specific recurrent physical complaints. So things like recurrent stomach aches or headaches and things. Drastic behavioral and personality changes, if they've been feeling very sad or withdrawn for more than 2 weeks, frequently involved in fights at school, serious attempts at self-harm, binging and purging, substance use, extreme difficulty in concentrating or hyperactivity, and then severe mood swings. So remember that these patients are often referred from school where they've already been seen by a school counselor or social worker, and then they get referred to us. A lot of the time we don't see these children because they go straight to child psych. And then the last section, just life-threatening extrapyramidal side effects. So these are secondary to neuroleptic drugs, which are antipsychotics. So the first one is acute dystonia. This is something that develops over 4 to 7 days. It's painful contraction of muscles that results in abnormal movements or posture. So it can present as torticollis, trismus, laryngopharyngeal spasm, and an ocular gyrate crisis. And it's treated with piperidine. And then the second one is neuroleptic malignant syndrome. It develops over 24 to 72 hours. The most important things here are that the patient is hypothermic, rigidity, and they can develop renal failure from rhabdomyolysis. So it looks very similar to malignant hypothermia. And then in terms of management, so it's important to recognize this early, withdraw any offending agents, resuscitate these patients. So we need to secure the airway, can hyperventilate them to blow off a lot of the carbon dioxide because they're in a hypermetabolic state. We need to fluid resuscitate them. They really need a lot of fluid. Then our specific therapies are dantrolene and bromocriptine. Then these patients will be admitted to ICU. They need to have supportive care, and DVT prophylaxis, antiarrhythmics, etc. as needed. Okay, and then finally, if we just come back to these cases. So just again, now that we've gone through everything, just to show what we would think of in these different cases and what would be the top of our different diagnoses. So the first patient, the elderly patient, they would be thinking, with delirium, he's a known diabetic, it can be an HHS, CVA, or he might have renal failure, he might have uremic encephalopathy. The second, the 30-year-old female, they would be thinking more of substances, or it can be a primary psychotic condition. And then with the 2 children at the end, they would be thinking more of, it's 2 children, the strange behavior happening at the same time. It would be more sort of poisoning, or have they used substances, or did they accidentally take their mother's medication, and so on. Right, and then there are my references, and we're done with 1.5 minutes left, if there are any questions from anyone.
Thank you, Amy. I have a question for you, and probably for everybody else. Which of the sedatives is the biggest cause that predisposes to delirium that we probably need to be very mindful of in the ED?
I thought that it was diazepam, but I could be wrong.
Actually, midazolam, because it's probably the benzo that's used the most.
Okay.
And midazolam is notoriously associated with delirium.
Okay.
So we have to be quite mindful when we're keeping patients ventilated and sedated in EDs, that we analgesize them really, really well and sedate as needed. Bear in mind, when they are extubated, they might be a bit delirious if they've been getting lots and lots of benzos. Yes. Cool. Your talk was excellent. I know we run out of time, so I'm going to log off and say thank you very much. And please do save and convert it so that you've got a record of your talk.
All right.
Thank you so much.
Thank
you.
Bye.